One of the bigger changes that we are faced with is now IOP, which is level of care ASAM 2.1, is no longer a time-based service. We are paid a per diem rate, meaning we get a flat rate for that service, whether we provide the services for 2 hours and 1 minute, or we provide the service for 19 hours. Because that's the threshold for this level of care, is the amount of service is anywhere between 9 and 19 hours. Yes, Val?
No, the group though is still 2 hours and 1 minute up to 3 hours. But we'll get paid for anything for the level of care 9 to 19 hours. But the individual time.
Correct, I was going to get to that. This is talking about just the group, the IOP group, okay? So, the conditions for us to be able to use this H0015 code for the per diem is that you must have a 1 to 12 practitioner to client ratio. The individual must be screened and appropriate for level 2.1. The individual must be in group for 2 hours and 1 minute. That's the rule of halvesies coming into play. Other services can be billed in addition to the H0015. So on top of the 2 hour and 1 minute group interaction, you can bill for individual therapy. We can bill for farm management services. But that's outside of this per diem rate. Did I say that correctly, Val? Okay. Again, it must be led by a clinician who is licensed. We cannot afford to have a CDCA lead an IOP group because it's a difference of almost $50. The other trick is that you can only build one per diem charge per patient per day. So if somebody is in an IOP group for 2 hours in the morning and an IOP group for 2 hours in the afternoon, we get paid the same amount. There's no two per diem charges. Yes?
Okay, so you said like the time levels are not the same anymore, obviously. But if you're billing for an IOP, if you're doing 2 hours and 1 minute of service in that day, correct?
Correct.
So we're not required to, what is the minimum, we don't have a week requirement, like minimum a week to bill for IOP now? Or?
IOP is 9 to 19 hours per week. When you start applying the rule of halvesies, the bare bone minimum is 6 hours and 3 minutes. So, the per diem requires that we provide 9 to 19 hours of services a week. That includes not only the IOP group, but the individual services or the MedSom services or anything else on top of that, or case management. We use the H0015 code, so that 2 hour plus 1 minute. But again, all the billing has to go under the licensed practitioner. Otherwise, we get paid the lower rate, and that's not an option for us. So here's an example of an IOP group with 6 patients led by a licensed practitioner, and shows the different codes that you would use. So if somebody is in group for the 2 hours and 1 minute, you would still use the H0015, but if it's for less than an hour, you use the 90853, so that we can still bill for that time even if they don't meet the 2 hour and 1 minute minimum threshold. Same scenario when you're co-facilitating. If you have 3, 6, 9, 10, 11, 12, 13, 15 people in group, you have 2 clinicians, one who's licensed, one who isn't, who's a trainee or assistant. There's where the modifiers come into play, but it's the same concept. Everything will go under the licensed clinician. Okay. All right, let's move on to level 3 ASAM for residential. This applies to all of the residential facilities who are going to be considered ASAM level 3.1, which is low-intensity residential treatment, and high-intensity residential treatment level 3.5. After the assessment is completed, one of the questions that we have been asking all along is, at what point do you bill the per diem charge for residential services? And Doug Day, who is one of the head honchos in the Department of Medicaid, recently finally said in a session that you bill the per diem rate the day that the client is going to be spending the night. So regardless of whether the patient comes in at 9 in the morning or at 11:59 at night, if they're going to be staying the night, after the assessment is done, that's when we start using the residential per diem. All of the services, individual, group counseling, regardless of how many hours of the day, are all billed under this per diem rate. That also includes all of the farm management services. Because according to the new Medicaid rules, if you are meeting this level of care, they're going to provide us or pay us for the day, regardless of what service we provide. But we can bill separately for room and board and the medication charges, but not the administration of the medication. So, the codes that you would be using are depending on what level of care your client is in. And I believe this is a change, and correct me if I'm wrong, in terms of how we are conceptualizing the residential services. Because one of the other big changes for residential service is that this has to do with prior authorization that we're going to talk about in a little bit. But if my understanding is correct, somebody will come in at the ASAM level of care 3.5, and as they progress through treatment, may progress down to the lower level of care, which has a lower rate of service. Did I say that correct? Okay. And again, this is all billed under the provider overseeing the treatment, i.e., usually it's going to be billed under the program director. All right, well, with withdrawal management levels of care, this applies primarily to RECOR and to our Alliance Detox unit. RECOR has a variety of services and a variety of level of cares. And as a result, we'll be doing a variety of different things. How did I do, Wendy? Okay. The billing out at RECOR is going to be a little bit of a challenge because of the different services that you all provide. Somebody who is part of the OTP level of care will be billing for the medications and services separately. For those who are the ambulatory detox, but they're not staying, and they're only there for up to 4 hours, those medication and services are billed separately. But if they are there for more than 4 hours, then they're billed on a per diem basis. So needless to say, RECOR's life is getting far more complicated. Woo-woo, all right? And Alliance is under the same boat. So you're not alone, Wendy and April, because they too are providing similar levels of care of service. They too will be either billing a per diem charge if there's somebody who's truly in the detox, or if they are doing the level 1 withdrawal management, the OTP component, they'll bill for the services separately. Which transitions into this new concept called prior authorization that is going to impact us quite a bit. And that there's 3 scenarios in which prior authorization is going to be needed. There are certain scenarios where it's always required, some scenarios when it's based on the billing provider, and then some scenarios based on the actual Medicaid enrollee. This chart here shows all the different services that are going to require a prior authorization in some capacity or another, and it will define what that requirement is. So there are certain services, such as ACT services that require prior authorization before you can even bill. That doesn't apply to us. Our IHBT team is another example of a prior authorization where before they can get signed up for this service and we can bill for that service, we have to get approval that they meet that level of care. The other prior authorization is for substance use partial hospitalization, but since we're not providing that service, we don't need to worry about that. Scenario number 2 is when you're asking for prior authorization per provider. This applies to that rule of you can do 1 diagnostic assessment a year. It's 1 encounter per person per calendar year per provider. If we were to attempt to do a second diagnostic assessment, we would have to get permission. We're not even going to try. It's not worth the hassle. One of the details that has yet to be worked out, and correct me if I'm wrong, Shelley, is they haven't even decided who is the prior authorization agency, correct?
Right.
Yeah, so we don't even know who to submit the prior authorization to, let alone,
No, we need to get that. They have a webinar.
It's in the MIDS portal, is where there's.
Okay.
We've kind of been talking about it.
okay, I stand corrected. It's in the MITS portal, but the details of the prior authorization have yet to be worked out.
We have all those too.
Yeah, okay.
And then there's also MyCare, which is a different form, it's a fax form.
Yeah. So here's an example of why we made the change of a diagnostic assessment or comprehensive assessment to be only 60 minutes. If you do the math, previously when we would do it for 90 minutes, we would bill for the time because it was a time-based service. We would get $194.98. If we provided that same service for 90 minutes, we would only get paid $111.11. So that means $83 are out the door for us. Whereas if we do a 60-minute assessment, which is now what we're doing, we're only going to lose $18.88 per assessment. So we are not getting paid as much for the same service that we're used to doing. This is an example of why we have to make changes as of January 1. Every agency throughout the state of Ohio has to do business differently. Now, there's a difference between a mental health assessment versus an AOD assessment. If you do the AOD assessment, which is H0001, we are allowed 2 units or 2 hours per calendar year per Medicaid enrollee per provider. And if you go over that, we would have to get prior authorization. Again, we're not even going to try to do that. Other prior authorized services have to do with psychological testing. We can do up to 12 hours per year per enrollee, except for a certain type. I think it's the neuropsych testing that is allowed up to 8 hours. And again, if you exceed those limits, you have to get authorization. Again, we're not even going to try that. For substance abuse residential, the per diem, you get the first 30 days. You can bill the first 30 days as a per diem rate. After day 30, you must get authorization for every service after that, for the next 30 days, I believe. So one of the ways that all the residential units are going to have to start planning is at day 21, you're prepping for requesting for additional time. And you're going to need to be able to substantiate why you need additional time. So the days of, well, it's an automatic 90 days of residential treatment are gone. It's an individualized amount of time based on what we can substantiate clinically. It also has to do with the number of residential stays within a calendar year. This rule applies for the first 2. Any stays after that are going to always require prior authorization. So let's say, for example, somebody goes to Wilson Hall in January, they leave February, they come back in April, they leave in June, and then want to come back in November. That third time, you don't get the first 30 days automatically. The third time, you must get prior authorization. So again, it's a new way of doing business for us. The SBIRT screenings are another example of a prior authorized service. You get one each year. We are still evaluating how we would use the SBIRT within the organization. And supported by interactive complexity because of the following. That way it's clear as mud why we have the add-on code. All we would need is Medicaid to come in and do an audit and see all these interactive complexities, and we don't have it clearly documented. So this should be a stock phrase for you to remember. Any other questions about interactive complexity? All right. We had a question back here about how does this apply to the EHR and with interactive complexity? How am I going to do that? With these add-on codes, you are going to start seeing for all of the services that have interactive complexity the option of having multiple codes selected, multiple billing strips. You already see it on the individual progress note. Work is underway to make this happen for the group progress note as well, and for the prog note evaluation, so that you will submit your 90837 for your assessment, and then you'll add your add-on code for interactive complexity as a second line. You're also going to see changes that have to do with the supervision changes, the general versus direct, and I think you already see them, but you may not have paid much attention to them. That if you go down to that billing strip area, you're going to see a little checkbox that says direct supervision, and you're going to see a line that's going to denote who the supervisor is, and that supervisor data field is automatically going to populate with whoever your clinical supervisor is as assigned in the system. You will have the ability to change that person's name. If, let's say, I have John Michael, who's a counselor trainee out in Massillon, and his normal supervisor is Karen. But Karen is not on site out at Massillon, I am. When he writes his progress notes, he can then change to my name. It gets billed under my rate, because I was on site and directly available and immediately interruptible. Karen wasn't directly available because she was at a different site. So even though that automatically will populate, you will have the option of changing whoever is on site. And that there should be some kind of a rotation schedule that if your immediate supervisor isn't available, then it's my responsibility as the supervisor to say, you need to make sure that so-and-so is available, and use that individual and talk to so-and-so and say, hey, I need you to cover for my trainee because I'm not going to be here tonight. Yes?
Again, this is only for counselors, social worker trainees, and CDC.
Trainees and assistants only. It originally applied to dependently licensed. Thank God there were enough agencies that said this is absolutely ridiculous, you were going to kill us, that got changed. Yes, sir?
What level of licensure do you need to be a supervisor? Rank supervisor.
That would be the way that it is now. An LPCC, an LISW, an LICDC. All the independently licensed clinicians. But if you're working with a trainee, then by default you must have the S designation on top of that as well. Okay? So what happens behind the scenes is there's this staff configuration template that will automatically assign Karen as John's supervisor. So it'll automatically pull through. You won't necessarily have to add that every single time. You also have to understand that your progress notes will assume general supervision unless you checkbox the direct supervision and you then say who that supervisor is. So it requires extra effort. And when you check that box on the progress note, it will say this service was provided under the direct supervision of Greg Emanuelson, LPCCS. The SIM codes are in the final stages of being written, and they will be distributed shortly, I believe next week, when we come out and do the individual program sessions, so that we'll have that all ready to go for you. That way you'll have your cheat sheets and understand how these work and what's different. I have been spitting a lot of information at you in a very short amount of time, and you guys have done a really great job of keeping your attention, asking great questions. There's a lot of resources available to you. You can go to the BH Redesign website and get the manual. You can go to the BH website and get all the codes and all the rates, and you can look at them. It can be mind-numbing at times. If you need something to fall asleep at night, I guarantee you this will do it to you every single time. The website is the bh.medicaid.ohio.gov. This is the resource, and everything flows out of this particular website. The manuals, the rates, training opportunities, and the billing related stuff. So the manual, you can get direct access to, and the workbook code sheet.